Systemic therapy, the focus was on adjuvant chemotherapy, I think is kind of a highlight film for precision medicine today in the United States. Not only for oncology, but also for non-oncology conditions. The algorithm that helps doctors decide, medical oncologists decide, who would benefit and who would not benefit by chemotherapy has really improved over the last 20 years. And as medical oncologists know, 20 years ago, we used tools like the extent of disease to largely determine whether a patient, recommendations for chemotherapy. There's been a sea change now. As medical oncologists know, the use of genomic gene expression testing and the recognition that breast cancer is really several different biologic subtypes for which treatment needs to be targeted has given doctors the tools to do much better at targeting. So the combination of ER, PR testing, HER2 testing, 21 gene assay testing, and the limited information about pathology, nodes positive or not, largely determine whether a medical oncologist today in the United States recommends for or against chemotherapy. Our research shows in large population samples of patients in the state of Georgia and California, which is our laboratory, that very few patients leave the exam room without a clear recommendation for or against chemotherapy. Only 15% of patients reported that the doctors left it up to them, dangled the uncertainty of whether they should proceed or not. The 85% of the patients reported a definitive recommendation for or against chemotherapy. That was very satisfying to patients. Patients don't like to be dangled. Patients want to know whether this treatment, which is quite morbid, is going to benefit me or not benefit me. And because evaluative testing has progressed and precision of that has progressed, that very few patients are left leaving the exam room, this is patients with favorable disease, with dangling about whether they should or shouldn't. That's a major advance in precision medicine in the United States today.